Imagine walking into like a really high-end clinic for a quick 30-minute cosmetic laser treatment.
Mhm.
It's marketed to you as a simple lunchtime fix for vaginal tightening.
Right, just in and out.
Exactly. But instead of being whisked into a treatment chair, you walk out with a referral for a pelvic MRI, a rigorous psychological evaluation, and strict orders to immediately stop taking your daily fish oil supplement.
Yeah, which sounds completely wild to most people.
It really does. So welcome to the surprisingly intense medical gauntlet of aesthetic gynecology. Today, on this deep dive, we are tackling a very specific mission. We want to know what pre-treatment checks should be done before vaginal tightening.
And it is a phenomenal question, really, because the answer reveals just how complex this area of the body truly is. I mean, we are looking at a space that completely blurs the line between a simple aesthetic desire and, deep systemic pelvic floor health.
Right.
A responsible clinician just cannot isolate one piece of tissue without understanding the entire biological ecosystem it lives in.
To understand that ecosystem, we pulled together a pretty massive stack of sources for you today. We're digging into the strict regulatory guidelines from NICE, that's the National Institute for Health and Care Excellence.
Which are incredibly thorough.
Oh, absolutely. We also have the protocols from the RCOG, the Royal College of Obstetricians and Gynecologists, plus statements from the FDA, and these really detailed step-by-step clinical protocols from high-end practitioners.
Yeah.
So, okay, let's unpack this, because what might be marketed online as a quick cosmetic fix actually requires this staggering multi-layered investigation.
It really does. The pretreatment checklist we're exploring today is, well, it's essentially a masterclass in holistic medicine. You really see that in the very first phase of assessment.
They're baseline checks.
Exactly. It focuses entirely on fundamental cellular health and the biological environment. Because before any physical alterations or, energy-based devices can be used, the medical team has to establish a pristine baseline.
And that baseline starts with cytology. So the absolute non-negotiable first step across these clinics is a mandatory up-to-date cervical smear or a pap test.
Right, you can't skip that.
According to the NICE guidelines, clinicians are looking for any presence of atypical squamous cells or intraepithelial lesions within the previous 12 months. And for anyone listening who isn't a cytologist, an atypical squamous cell basically means a cell that looks a little warped or distorted under a microscope.
Yeah, it's an early warning sign that the tissue is under stress or potentially even mutating.
Right, and if there's any sign of precancerous cellular changes, everything just halts.
As it should. You cannot introduce a treatment designed to stimulate cell growth into an area where cells might already be mutating dangerously.
That makes total sense.
But the biological checks, they go far beyond just the cervical cells. I mean, the screening for active infections is incredibly aggressive.
Oh, yeah. Clinics require testing for thrush, bacterial vaginosis, and a full panel of sexually transmitted infections.
Which involves taking vaginal swabs and running urine samples to specifically look for, chlamydia and gonorrhea.
Which, logically, I get.
Yeah.
I mean, is performing this procedure without these checks basically like trying to paint over mold in a house?
That is a perfect analogy. Yeah.
You definitely don't want to trap a localized infection like thrush under healing tissue.
Wow.
But the protocols don't just stop at localized swabs. They demand systemic blood tests.
Yes, they do.
They are screening for HIV, syphilis, and hepatitis B and C. Oh, wait, I really have to push back on this.
Okay, good.
Checking for a local yeast infection makes perfect sense to me. But hepatitis C, that is a systemic blood-borne virus. Why is a systemic virus stopping a localized vaginal laser treatment?
Well, it comes down to the actual mechanics of how these treatments work. Whether a patient is opting for surgical reconstruction or a non-ablative fractional CO2 laser, the mechanism of action relies on creating controlled trauma.
Wait, trauma.
Yeah. Lasers work by delivering precise thermal injury to the tissue. They literally heat up the dermal layers to stimulate the body's natural collagen production.
Oh, wow.
And this process can lead to localized edema-like swelling or microscopic bleeding.
Oh, I see. So you are intentionally injuring the tissue to force it to heal stronger.
Exactly. So if the patient's body is currently fighting a heavy blood-borne pathogen like hepatitis C, their immune system is deeply compromised. Their healing process just won't respond to that thermal injury the way a healthy system would.
You might just cause permanent damage.
Right. And furthermore, you have to consider the safety of the clinical staff handling the equipment and, the microscopic blood spatter. Establishing a standard of systemic baseline health protects everyone in the room.
Okay, so let's say the blood work comes back clear, the cellular health is confirmed, and the swabs are negative. The invisible biological threats are ruled out.
Right. Baseline is clear.
This is the part of the protocol that actually blew my mind, because the clinician's focus now zooms out to the macro level. We move into mapping the physical terrain.
Yes, the structural mechanics.
They have to look at the entire pelvic floor, primarily to rule out hidden conditions that are masquerading as simple looseness.
Because the concept of laxity is incredibly subjective. A patient might sit down in the consultation room and say, they feel loose or they feel a loss of sensation.
Right.
But the clinician's job is to figure out the underlying mechanical failure causing that sensation. And to do that, they utilize the POPQ system, the pelvic organ prolapse quantification system.
And that's a physical exam, right?
Yes, it's a very specific physical exam that measures exactly where the pelvic organs are sitting.
And the guidelines are rigid here. If a patient scores a stage 2 or higher on that POPQ scale, they are entirely disqualified from simple cosmetic laser tightening.
Absolutely.
For context, for you listening, a stage 2 prolapse means the bladder, the uterus, or the rectum is literally descending and pushing into the vaginal canal.
And firing a superficial laser at the mucosal wall is not going to fix the structural collapse of the pelvic floor holding those organs up.
No, it wouldn't.
It would be like trying to fix a collapsing roof by putting a fresh coat of paint on the ceiling.
That's a great way to put it.
Because of this, the diagnostics often escalate way beyond just a standard physical exam. The sources outline the use of urodynamic monitoring to check bladder function, PAD tests to quantify incontinence, and even pelvic MRIs using a contrast medium.
Wow.
Yeah, some of the most advanced clinics are using translabial ultrasounds with 3D reconstruction. This allows the doctor to physically visualize the integrity of the levator animuscles, that's the main sling of muscles supporting the pelvis, to see if there are actual tears in the muscle fibers.
Think about that. You walk in asking for a quick cosmetic laser,
Right.
and you walk out with a referral to lay in an MRI tube.
It's intense.
But here's where it gets really interesting. While they are scanning the architecture, they also have to rule out completely different medical conditions, like GSM or genitourinary syndrome of menopause.
Right. GSM is a chronic condition that occurs when estrogen levels drop, usually during perimenopause or menopause. When that estrogen goes away, the mucosal lining of the vagina drastically thins out.
It loses its elasticity.
Exactly. It becomes dry and easily irritated. And to a patient, this loss of elasticity feels exactly like laxity.
Right.
But to diagnose this during the pre-treatment check, the clinician uses a brilliantly simple tool. They just use narrow-range pH paper.
No, I read about this. A healthy premenopausal vaginal environment is acidic. But the protocols note that if the pH paper registers greater than a 5, it actually supports a GSM diagnosis.
Yes.
So if it's GSM causing that feeling of looseness, firing a laser at it is the wrong approach entirely.
Completely wrong. They likely just need localized estrogen therapy to restore the tissue.
And the clinician is also visually hunting for chronic vulval dermatosis,
Yeah.
right? Like conditions like lichen sclerosis or lichen planus.
They have to. Lichen sclerosis, for example, causes the skin to become incredibly thin, white, and prone to tearing. If a practitioner misdiagnoses that as just normal aging and fires a high-energy laser at it, they aren't rejuvenating the tissue. They are severely burning compromised skin that simply cannot heal properly.
So the ultimate goal of this entire structural and diagnostic mapping is to ensure a doctor isn't using a high-tech laser to treat something that actually requires like pelvic floor physical therapy or hormonal cream or dermatological steroids.
Exactly.
But let's assume the structural anatomy is perfectly intact and the skin is healthy. What happens when you introduce a massive pulse of electromagnetic energy into that space?
Well, that brings us to the tech clashes.
Right. Because if a patient opts for the non-surgical route using devices like radiofrequency machines or erbium-YA lasers, their own internal hardware and medical history suddenly dictate whether they are safe to proceed.
The contraindications for these aesthetic devices are surprisingly extensive, and it starts with internal implants.
The checklists actively screen for pacemakers, which, most people would expect. But they also look for metal implants anywhere in the pelvic region, or even standard copper intrauterine devices like the copper IUD. Wait, let's pause on this.
Okay.
You're telling me a metal hip replacement could completely prevent you from getting a non-surgical cosmetic vaginal tightening?
Depending on the precise technology being used, yes, absolutely.
That is wild.
Let's look at radiofrequency treatments, like the MFMI 360 system detailed in the clinic protocols. Radiofrequency doesn't just treat the surface. It utilizes 360-degree volumetric heating.
Okay, so it goes deep.
Yes, it achieves this by passing electromagnetic energy deep through the tissue layers. So if you have a large internal metal implant, like a titanium hip replacement, near that treatment zone, it can interact dangerously with that electromagnetic field.
Like it could heat up?
The metal could potentially heat up, or it could disrupt and redirect the energy flow, which causes internal burns. Aesthetic gynecology is deeply tied to the systemic physics of the entire body.
Systemic physics, I love that term. And it's not just hardware either. They screen for photosensitivity disorders or if the patient is taking photosensitizing drugs.
Which makes total sense if you're about to bombard the tissue with a light-based laser.
Exactly. The NICE guidelines also highlight exclusions based on body mass index. Several clinical studies explicitly exclude patients with a BMI over 35 or under 18.5.
Right.
And they have to rule out severe systemic issues like chronic kidney or liver disease.
The clinical logic there is that extreme BMI or chronic organ failure severely alters the body's inflammatory response and circulation.
So it messes with the healing.
Yeah, making the results of a collagen-stimulating laser wildly unpredictable.
And then there's the timeline on topical products. The protocols state a clinician has to explicitly verify that the patient hasn't used local hormonal therapies, vaginal moisturizers, or even over-the-counter lubricants within a blackout period ranging from 30 days to 6 months prior to the assessment.
It's a huge window.
Why such a massive blackout period for something as simple as a moisturizer?
Because those products artificially manipulate the cellular environment. A high-quality moisturizer changes the fluid content of the epithelium. It plumps the cells up.
Oh, so it fakes the health of the tissue.
Basically. A local estrogen cream thickens the mucosal lining. If a clinician uses their instruments to assess the tissue while it's being artificially supported by these products, they are getting a false reading of the baseline laxity and atrophy.
That makes a lot of sense.
Plus, residual oils or compounds in the tissue can interact unpredictably with laser energy, which could potentially cause surface burns.
Wow. So if you are listening to this and you use a standard over-the-counter intimacy moisturizer, your tissue is currently disqualified from an accurate medical assessment.
Yep.
It completely changes how we view these everyday products.
Right.
But all of these tech clashes, the lasers, the metal implants, the moisturizers, that only applies to the non-surgical route.
Right.
What if the patient bypasses the lasers entirely and opts for a surgical vaginoplasty?
The pre-treatment checks escalate dramatically the moment a scalpel is involved. We move from systemic physics into heavy, traditional physiological and lifestyle screening.
Like standard surgical prep.
Standard surgical prep kicks in immediately. We're looking at chest x-rays to ensure lung capacity, ECGs to check the electrical rhythm of the heart, and mandatory MRSA screening.
The MRSA screening caught my eye. They take swabs of the groin, but also the inside of the patient's nose.
Yes.
Why swab the nasal cavity for a pelvic surgery?
Because MRSA, which is a highly antibiotic-resistant bacteria, often colonizes in the warm, moist environment of the nasal passages.
Oh, I see where this is going.
Yeah, a patient could just touch their nose, touch their surgical site, and introduce a devastating, treatment-resistant infection right into a deep surgical wound.
Incredible. And the lifestyle checks are just as intense. Patients have to confirm they will stop smoking completely for 4 to 6 weeks before surgery.
Because smoking causes vasoconstriction.
It literally starves the healing tissue of oxygen, right? They also have to halt medications like aspirin and ibuprofen. But what really stood out to me on the surgical workup was the supplement list. Patients are ordered to stop taking fish oil, ginkgo biloba, and St. John's wort.
Those specific natural supplements are known to inhibit platelet aggregation.
Which means?
In simple terms, they make it harder for your blood to clot. The pelvic region is highly vascular. It is packed with a dense network of blood vessels.
Right.
Preventing excessive, uncontrolled bleeding complications during a surgical reconstruction is paramount. So anything that thins the blood has to be completely flushed from the system.
But out of all the surgical prep questions, there is one that carries an immense amount of weight, and that's the obstetric history check.
Yes, this is a big one.
Clinicians are required to explicitly ask the patient if they are done having children. So a surgeon actually has to evaluate your future life plans, not just your current physical anatomy.
If we connect this to the bigger picture, the anatomy and the future life plans are inextricably linked in this scenario.
How so?
Well, during a surgical vaginoplasty, the surgeon is often operating on the levator ani muscles, those shelf-like muscles on either side of the pelvic floor. The goal is often to bring those stretched muscles closer together, suturing them tightly, almost like a corset, to reduce the vaginal diameter.
Okay, I'm visualizing that.
If that patient later decides to have a child and goes through a vaginal delivery, a baby's head passing through that surgically repaired canal will act like a battering ram.
Oh, wow.
It will rip those sutures apart, completely reverse the costly and painful surgery, and potentially cause massive scar tissue trauma. So family planning is an unavoidable medical prerequisite.
It makes complete biological sense, but it is a heavy, deeply personal question to have to answer before a cosmetic procedure,
It really is.
which transitions us perfectly into the next and arguably the most delicate hurdle of the entire process,
Mm-hmm.
the psychological clearance.
Yes.
Clear the cells, the structure, the hardware, and the lifestyle. Now, the clinician has to pivot to evaluating the patient's mind-body safety.
This is where we are seeing a massive necessary shift in regulatory focus across the entire aesthetic industry. The Joint Council for Cosmetic Practitioners, the JCCP, they mandate a psychosocial assessment to explicitly screen for body dysmorphic disorder, or BDD.
The sources mention that BDD affects about 0.5% to 0.7% of the general population. But the prevalence is shockingly higher in people seeking aesthetic treatments.
It makes sense when you think about it.
Yeah. BDD is characterized by an excessive, obsessive preoccupation with an imagined or very slight defect in appearance. And the clinicians aren't just guessing, right? They're required to use validated screening tools.
Right, like the appearance anxiety inventory, the AAI, or the face Q.
But these aren't just simple "are you sad" questionnaires, are they?
Not at all. Let's look at how a tool like the appearance anxiety inventory actually works. It measures cognitive and behavioral processes.
No.
It asks highly specific questions like, how much time per day do you spend thinking about this specific feature? Or how often do you avoid social situations or intimacy because of your appearance? Or how many times a day do you check this body part in a mirror?
Wow, those are very pointed.
Yeah, the clinician is looking for behaviors that indicate the physical defect is causing a disproportionate disruption to the patient's daily life.
The guidelines also warn clinicians to be on high alert for cosmetic shoppers.
Yes.
These are patients with a documented history of bouncing from clinic to clinic, seeking multiple different interventions with diminishing satisfaction each time. They also screen for camouflaging tactics. It sounds like the doctors are forced to play psychological detective here.
They absolutely are.
They have to figure out if the patient is secretly trying to fix an internal emotional pain or like a relationship issue using a physical laser.
Because the psychological vulnerabilities in aesthetic patients are undeniable. The JCCP guidelines clearly state that offering psychoeducation is a required standard of care.
Meaning they have to teach the patient about their own psychology.
Basically, this means a clinician might actually have to sit down and challenge a patient's deeply held beliefs about the role of physical appearance and self-worth before any physical intervention can even be considered.
And this all culminates in the consent process. The clinic protocols are adamant that it isn't just a signature on a clipboard at the reception desk.
Right, it's not just a waiver.
It has to be a full consent process that explicitly breaks down the science of the treatment, the thermal injury, the risks, and prominently features a no guarantee clause.
And that no guarantee clause isn't just legal protection for the clinic, it is a psychological tool.
How so?
It forces a realistic alignment between the patient's expectations and the clinical reality. Managing expectations upfront is the absolute best defense against severe post-operative psychological distress.
Okay, so we've covered the cellular cytology, the structural pelvic test, the technological physics, the surgical blood thinners, and the psychological evaluations.
That's a lot.
It is a lot.
Uh.
But the final check in these guidelines plunges into the patient's deep history. This ensures that cultural, historical, or previous surgical traumas are identified, because these don't just influence the treatment pathway, they often completely rewrite it.
They really do. The Royal College of Obstetricians and Gynecologists provides very clear, stringent mandates here that require immense sensitivity. Gynecologists must explicitly ask all women from communities that traditionally practice female genital mutilation, or FGM, whether they have undergone the procedure.
And it goes beyond just asking, right?
Right.
The clinician has to visually inspect the tissue to determine the specific type of FGM, because the physical realities of the tissue fundamentally change what is medically possible.
Exactly.
The guidelines heavily focus on type 3 FGM, which is also known as infibulation. This involves the narrowing of the vaginal orifice, often through the creation of a covering seal by cutting and repositioning the labia.
And this changes everything medically.
Right. If a patient has type 3 FGM, you physically cannot perform the mandatory pap smear. You cannot insert the speculum for the POPQ prolapse test.
The standard diagnostic pathway is completely blocked. In those cases, the patient might require a deinfibulation procedure, which is a surgical opening of the tissue long before standard gynecological care or infection screening can take place.
Let alone a cosmetic tightening procedure.
Exactly. Furthermore, the clinician has to evaluate the area for FGM-related morbidities, like epidermoid inclusion cysts.
What are those?
They're painful lumps that form when surface skin cells get trapped deep in the tissue during the original trauma. These fundamentally alter the surgical landscape.
And the pretreatment checklists also have to deeply adapt for transgender patients. The STI swab protocols we mentioned in step 1, they completely change depending on the patient's surgical history.
Yes, they do.
The Let's Talk About It guidelines specify that if a trans woman has had a previous gender-affirming vaginoplasty, a standard frontal swab is entirely ineffective. Because the mucosal environment is fundamentally different, a urine sample is required to get an accurate chlamydia and gonorrhea result.
Wait.
It's profound how heavily a patient's past, their previous surgeries, their cultural background, how much that dictates the medical reality of their present.
This raises an important question, though. It highlights why standard checkbox cosmetic intake forms are entirely inadequate for this area of medicine.
Yeah, a simple form isn't going to cut it.
No. A true pre-treatment assessment requires a practitioner to read the tissue, knowing that the tissue tells the story of the patient's entire life. You aren't just treating a symptom of laxity, you are navigating a deeply complex human history.
So what does this all mean? We started this deep dive asking what pre-treatment checks should be done before vaginal tightening. We looked at a procedure that is constantly marketed on social media as a quick, easy way to boost confidence.
A lunchtime fix.
Right. But what we actually found is a rigorous, unforgiving gauntlet. You have to clear cellular cytology. You have to pass the structural POPQ test. You might need a 3D ultrasound.
You have to clear your body of metal implants and your daily fish oil.
Exactly. You must undergo behavioral screening for body dysmorphia and navigate complex cultural and surgical traumas.
Because it requires a profound level of diagnostic respect. The medical community recognizes that the pelvic floor is the structural, hormonal, and psychological epicenter of the female body. You simply cannot tighten it without thoroughly investigating everything else that is happening systemically.
Which leaves us with a final thought for you to mull over. If our bodies demand this profound level of diagnostic respect, holistic screening, and psychological clearance before a single cosmetic enhancement can take place in this area,
And it absolutely demands it.
shouldn't we demand that same rigorous standard of assessment for all the quick-fix wellness trends and aesthetic procedures we are marketed every single day?
We so often treat our bodies like isolated machines that just need a quick, localized tune-up. But these protocols prove that we are intricate, highly interconnected ecosystems.
Exactly. So the next time you see an ad promising a simple 30-minute fix, remember the intense reality of the medical gauntlet. True precision isn't about ignoring the complexity of your body. It's about investigating every single layer before you ever decide to try and paint over the mold. Thanks for joining us on this deep dive. Keep questioning the world around you.